Hello and namaste to everyone. I'm Name-Shalu Singh from the Department of Physiotherapy and Diagnostics in Jayoti Vidyapeeth Women's University. For today's lecture, we'll be discussing about high anion gap metabolic acidosis, normal anion gap metabolic acidosis. These high anion gap metabolic acidosis and normal anion gap metabolic acidosis, these are the conditions which are signified under disturbances in acid-base balances. So, in acid-base disturbances, it is classified as acidosis and alkalosis. So now these acidosis, they can be either metabolic acidosis or respiratory acidosis. For the alkalosis can be a respiratory alkalosis or metabolic alkalosis. Respiratory acidosis, in case of respiratory acidosis, there is primary excess of carbonic acid, whereas in metabolic acidosis, there is primary deficit of bicarbonate. In respiratory alkalosis, there is primary deficit of carbonic acid, and in case of respiratory alkalosis, there is primary excess of bicarbonate ions. Now for today's lecture, today's lecture we'll be focusing on high anion gap metabolic acidosis. I've told you earlier what is metabolic acidosis. First of all, so metabolic acidosis, it is due to the primary deficit in your bicarbonate ions. Now see, as the name signifies, high anion gap. So what was the anion gap? It was basically, as we say, that the sum of cations and anions in ECF are always equal. So to maintain the electrical neutrality, so sodium and potassium, they basically constitute 95% of your cations, whereas chloride and bicarbonate, they account for only 86% of your anions. Only these electrolytes are commonly present in our body. So hence there is always a difference between measured cations and anions. So the unmeasured anions, they constitute basically the anion gap. And the normal value for anion gap is 12 millimoles per liter. Now the term high anion gap metabolic acidosis. The normal value was 12 millimole. Now the value between 15 to 20, it is accepted as reliable index of accumulation of acid anions in your metabolic acidosis. This is basically known as high anion gap metabolic acidosis. Now these can be seen in conditions of your renal failure. First of all, now this what is renal in renal failure, the excretion of hydrogen as well as generation of bicarbonate, these are both deficient. So the anion gap increases due to accumulation of other buffer anions. So second condition is your diabetic ketoacidosis. And what is diabetic ketoacidosis? It is basically the life-threatening problem that affects people with diabetes, and it occurs when body starts breaking down fat at a rate that is much too fast, and the liver processes this fat into fuels called ketones, and which causes the blood to become acidic. Now, the next condition is your lactic acidosis. So, a normal lactic content in plasma is less than 2 millimoles per liter. And there are two types of lactic acidosis, type A and type B. So type A, in case of type A lactic acidosis, there is impaired lactic acid production with hypoxia, and it is seen in case of tissue hypoxia. That is in case of anaerobic metabolism. In case of shock, which can be either anaphylactic, septic, or cardiac. In case of lung hypoxia, carbon monoxide poisoning, and seizures. Now, second is your type B lactic acidosis. It is seen in case of impaired lactic acid metabolism without hypoxia, and it is seen in case of liver dysfunction, toxic alcohol and inborn errors, mitochondrial disorders, less oxidative phosphorylation, and more anaerobic glycolysis. So, in case of thiamine deficiency, defective pyruvate dehydrogenase. Now, in lactic acidosis, there is a case of increase in tissue hypoxia, circulatory failures, and in case of biguanides. Now, whereas in diarrhea, it causes normal anion gap acidosis and normal anion gap metabolic acidosis. We'll be reading it further. Now, for this thing, we'll further say that suppose there is, let's look into it, this example, like it says that suppose there is 5 millimoles per liter of lactic acid that has entered in blood. So now this is buffered by bicarbonate and it is resulting in 5 millimoles of sodium lactate and 5 millimoles of your carbonic acid. So now the carbonic acid is dissociated into water and carbon dioxide, which is removed by lungs through ventilation. So now the result into the resulting um, is lower. Result is lowering in bicarbonates by 5 millimoles, and the pressure of uh, 5 millimoles of unmeasured anion, which is a lactate with no charge in sodium or chloride. So anion gap will be increased. So further, in contrast, diarrhea will result due to loss of bicarbonate. Now, NaCl will be reabsorbed more from kidney tubules to maintain your extracellular volume and hence resulting in increase in serum chloride. Now, this chloride compensates for fallen bicarbonate. So, diarrhea may result in hyperchloremia and normal anion gap and metabolic acidosis. So, this gap may apparently be narrowed down with cations and cations are decreased, cations such as potassium, magnesium, and calcium, or when there is hypoalbuminemia. And then similarly, a superior elevation is seen in case of hypergamma globulinemia, or when positively charged proteins are elevated, or when cations are increased, or in case of your alkalosis, or when negative charges of albumin are increased. Now, the next term which comes is normal anion gap metabolic acidosis, or NAGMA. Now, there is loss of both anions and cations. The anion gap is normal, but acidosis, it may prevail. So, the causes are, first of all, is diarrhea, which is loss of intestinal secretions, which lead to acidosis. Bicarbonate, sodium, and potassium are lost. Hyperchloremia, chloremic acidosis, which may occur in renal tubular acidosis, azithromycin, then carbonic anhydrase inhibitor therapy, and ureteric transplantation into large gut, which is done for bladder carcinoma. Now, there are several causes of a higher anion gap metabolic acidosis. First one, as I told, renal failure, and it remarks sulfuric acid, phosphoric acid, organic anions, decreased ammonium ion formation, sodium hydrogen exchange, which will result in decreased acid excretion. Whereas in case of ketosis, it remarks acetoacetate, beta hydroxybutyrate anions. It is seen in case of diabetes mellitus or starvation. In case of lactic acidosis, there will be remarks of lactate anion. It will accumulate when the rate of production exceeds the rate of consumption. Now, causes are your next cause will be your salicylate, which is seen in case of aspirin poisoning. Next is in case of amino acidureas, which remarks acidic metabolic intermediates and accumulation of block in normal metabolic pathway. Third is your organic aciduria, seen in case of organic acids, methylmalonic acid, propionic acid, and it is excreted. Next cause is your methanol, which remarks formate, glycolate, oxalate, and acids formed will lead to increase in Ag, and there is increase in plasma osmolality, and so osmolar gap is also increased. So in drugs, it is in remarks the case of corticosteroids, dimercaprol, ethacrynic acid, furosemide, methanol, nitrates, salicylates, and thiazides. Now, as we were talking about the causes of normal anion gap metabolic acidosis. So the first one was diarrhea. Second was one was hyperchloremic acidosis. Now the third one here is next will be renal tubular acidosis, which may be due to failure to excrete acid or reabsorb bicarbonate. Next is your chloride is elevated since electrical neutrality has to be maintained. In uteric transplantation, the chloride ions are reabsorbed in exchange for bicarbonate ions lost, and it will lead to hyperchloremic acidosis. Now, acetozolamide therapy, it will result in metabolic acidosis because HCO3 minus generation and hydrogen secretion are affected. Now, the last thing is urine anion gap, which is useful to estimate the ammonium excretion and is calculated as UAG, which is equal to UNA plus UK. K is your potassium here and Na is your sodium, and with UCl, Cl is your chloride ions. Now the U here stands for your urine. Now, the normal value of urine anion gap is -20 to -50 millimoles per liter. In case of metabolic acidosis, the NH4Cl excretion increases and urine anion gap becomes -75 or more. But in case of RTA, ammonium excretion is defective and UAG has positive value, and causes of RTA are further type 1. There are further causes of renal tubular acidosis, which is RTA. So the type 1, it can be in case of proximal RTA, which is multiple myeloma, amyloidosis, heavy metals, lead, mercury, Wilson's disease, galactosemia, hyperparathyroidism, paroxysmal nocturnal hemoglobinuria, acetozolamide. For type 2, it's distal RTA, and next examples will be autoimmune disorders, SLE, rheumatoid, hypercalciuria, amphotericic B, lithium, obstructive neuropathy, and Marfan's syndrome. For type 4, there is impaired aldosterone function. Now, we read the term anion gap. So, if there is a decrease in anion gap, so following conditions can be seen in case of decreased anion gap. First one is hypoalbuminemia. Second one is your multiple myeloma. Third one is your bromide intoxication. Fourth one will be your hypercalcemia. So, serum albumin levels and anion gap. So, normal anion gap is affected by patient's serum albumin level, and as a general rule of thumb, the normal anion gap is roughly 3 times the albumin value. An example for a patient with albumin of 4.0, the normal anion gap would be 12, and for a patient of chronic liver disease and an albumin of 2.0, so the upper limit of normal for the anion gap would be 6. Now the ceiling value for normal anion gap is reduced by 2.5 for every 1 gram per dl reduction in plasma albumin concentration. Now the next term that comes up is your osmolar gap. So what is osmolar gap? It is basically the difference between measured plasma osmolality and calculated osmolality, which may be calculated as 2 into concentration of sodium plus concentration of glucose plus the concentration of urea. Now, in case of normal anion gap metabolic acidosis, causes can be, as I've earlier told, that first cause can be your diarrhea, second cause can be your intestinal fistula. So it remarks loss of bicarbonate and cations, sodium or potassium, or both. Now, the second cause can be renal tubular acidosis, type 1, type 2, and next was your type 4. So, in type 1, it remarks defective acidification of urine, first or distal renal tubular acidosis. Next is your urine, where urine pH is less, more than 5.5 with hypokalemia and due to inability to reabsorb bicarbonate. So the compensatory increase in chloride, hypochloremic acidosis. For type 2, second or proximal renal tubular acidosis, urine pH less than 5.5 and K normal due to inability to excrete hydrogen ions. For type 4, resistance to aldosterone, urine pH less than 5.5, hyperkalemia, carbonic anhydrase inhibitor, loss of bicarbonate, sodium and potassium, similar to proximal RT. Then ureterosigmoidostomy, loss of bicarbonate and reabsorption of chloride and hypochloremic acidosis. In case of drugs, antacids, they containing magnesium, chloropropamide, iodide, these remarks can be seen. Now, the normal osmolar gap is less than 10 milliosmoles, and a high osmolar gap, it implies the presence of unmeasured osmoles such as alcohol, methanol, ethyl glycol, etc. Now, the acute poisoning should be considered in patients with raised anion gap, metabolic acidosis, and increased plasma and osmolar gap. Now, the poisoning with methanol, and ethylene glycol should be considered, and hence the metabolized to formic acid and oxalic acid correspondingly. Now, methanol will produce blindness. Ethylene glycol will lead to oxalate crystalluria and renal failure. Now, this was all for today. So we talked about high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So this is it for today. We'll talk about rest in next class. And until then, take care and goodbye.